all the way to PhD and MD students of a variety of majors, the task of coming together in just an hour with a policy proposal and being as clear as possible in an hour about what it would entail and why it would benefit the nation. So we appreciate you both being here to give any feedback on how they could take it to the next level after this early start. But I would love Emily and Andres to be able to introduce themselves to FIU alumni, now doing amazing things in the health space here in Washington, D.C. Our third panelist did indicate, yes, that deserves a round of applause, I agree. Our third panelist did tell me she'd be a little late, so if she shows up, we will get her introduced as well. But Emily, Andres, can you give us a quick overview of your FIU story and who you are, what you're doing here in DC these days?
Is this on? Oh, it is. Hi, everyone. I'm Emily Sanchez, and I am originally from Miami, born and raised. And when I was at FIU, I majored in political science and also did a major in criminal justice. I went on to get a JD and an MPH. And right now, I am a federal a manager for the Federal Affairs Office at Johnson & Johnson for the Janssen team. Before that, I did various public health roles, mostly within public health law and policy. So I worked with the Network for Public Health Law, and I've also interned and worked with the CDC Public Health Law program. So that's a little bit of my background. Now I'm in a pharmaceutical space, which is very interesting, and I'm working on more federal policy versus state, and I'm happy to speak with anybody about that if they're interested in that area.
Okay, cool. Hi, everyone. My name is Andres Alatorre Perez. I am an analyst at the Government Accountability Office. I'm there on the healthcare team. I'm an FIU alum. I graduated in 2020. I was doing a bachelor's in psychology, and I did my master's at the George Washington University. I just graduated in December. I did my master's in public policy, so that was really cool. Before that, I did a bunch of internships, some on the Hill, some in my district office. I was at a think tank where I got to work on Medicaid expansion policy, which is really fun, probably my favorite thing to do in healthcare policy. And the first time I came up here in DC was on a fly-in, so FIU is kind of always felt like a special part of that journey here in DC. So yeah, I'm just happy to be here.
Was that a health fly-in?
It's healthcare on the Government Accountability Office. So.
No, the fly-in that you did was.
Oh, the fly-in, yeah, it was a healthcare one.
Yeah, I think so. Yeah, so that was a previous iteration of what you're all doing today. So, hashtag this could be you. All right. I'm happy to turn it over to our first team.
Hi, everyone. Once again, I'm Noemi. To our panelists, I'm a first-year MA in English Literature student, and I do a lot of advocacy work in healthcare as far as equity, disabilities, visible and invisible, and other underrepresented communities.
Hi, everyone. My name is Saki, and I'm a second-year medical student at HWCOM.
Hi, everybody. My name is Katarina. I'm a second-year Health Services Administration major.
Good afternoon, everyone. My name is Tiara Campbell. I'm a rising senior majoring biology on a pre-med track, and I'm currently a case senator for SGA.
Hello, everyone. My name is Naomi Knight. I'm on a psychology pre-physical therapy track with a minor in African American studies. So our presentation focuses on federal prisons in Florida. So our problem specifically is the standardization of healthcare. Our problem specifically is the standardization of healthcare within federal prisons, specifically in the state of Florida. Yours is right there.
So essentially, what I wanted to focus on is why is it a problem and why is it significant? So essentially, what I was thinking was, why should the right of accessing healthcare be taken away just because you're in prison? Why should it be taken away? What's the real reason? And I think when people think of what the real reason is, it kind of is, oh, because they did something bad and they deserve it. But that doesn't equate, to their entire healthcare should be taken away. So I think the push for standardization would be really good because it ensures safety, accuracy, and equality in healthcare, and it allows it to be replicated to all people in that system. And so essentially, like bringing unity in the prison system, it also allows other agencies and other people to get involved, which also kind of puts a spotlight on something that's kind of not really like shown and a lot of people don't know about, which I think is really great. Oh, my bad. Okay, so essentially, healthcare is 20% of our GDP, and so essentially, whether or not somebody makes it out of the makes it out of the prison system, it will still be a financial burden. So, essentially, making it standardized would kind of like mitigate those costs in a way.
So I'll be presenting on who can assist the problem. So our team came up with a policy that will be entitled Rules, Regulations, and Guidelines for Healthcare Professions in Federal Prison. So in this document, it will be a standardized document highlighting different ways and the rules and regulations and how healthcare professions in the federal prison can treat incarcerated individuals. This would be important because healthcare professions can look back at this for guidance when dealing with different cases, and they could also, what if prisoners are mistreated during different healthcare interactions, their lawyers could go back and use this to help in their case. Also, a different way we can assist with this problem is teaching preventative health in prison. This would be beneficial. So, what did you say about it? I thought it was who can assist. Yes. Okay. Yes. Sorry. So, teaching preventative health. Another good way that we came up was public universities can partner with prisons to provide classes and enrichment to aid with the integration to society. And then we said that the Senate Committee on Health, Education, Labor, and Prevention could help, as well as the House Subcommittee on Health. And then we also said that the Payne Center for Social Justice could help with this.
I'm not sure why it did double page on ours, but I am going to present on the proposal. Obviously, I proposed this. I've been doing some work on this topic on my own accord, a lot more deep, like rooted, but I think it's a really great topic to touch on, especially after our last presentation that we had. So as far as the proposal, you heard a little bit already from my colleague here, Tiana, right? Yeah, Tiana. Tiara, there you go. Listen, I feel like she's Tiana, so. So our proposal, part of it would be kind of requiring a actual physician, because I have found from my prison exchange letter program that a lot of times the medical professionals who are inside prisons are not actual physicians. And I've even heard of them actually using WebMD to decide like what to do and kind of triage the patients inside the prisons. So I think one of the first ways to fix that is to require an actual physician to be at the property or at the prison. Additionally, we see the opportunity for collaboration. So a lot of medical students need to do a residency, need to get on-hand experience, want to get on-hand experience. So I think this is a really unique way for medical students to work on their bedside manner, approach non-traditional patients, and also have a really great impact in their local communities. And it also provides them an opportunity to just learn about what are the issues that we're actually dealing with, because a lot of these people, after they leave prison, they will go into the regular healthcare system that we all have and we all pay for. On one of the slides, it said that our 20% of our economy is going to be towards healthcare costs. And as some of you may know, the US, we have some of the most highest healthcare costs, but we actually don't have the most effective. So that's another way of addressing the issue of accessibility and cost. Additionally, as far as the standardization of healthcare that we're proposing, it would be kind of like a handbook and something that is meant to list out rules, expectations, and regulations. And while, of course, each state, each prison, each population has their own unique set of needs, issues, and things like that, we want to use this as a way to help ensure widespread equality and address the common issues that we find from state to state. Additionally, again, it's not going to cover the nuances, but it's a great way to start. And then finally, we see an opportunity for collaboration with a third-party entity that deals with medical malpractice. So maybe like a professional organization or other organizations that are really concerned about ethics in medicine. It could even be like a student union, things like that. And then that way we have a sense of checks and balances, and we just don't have full government overreach, and we're not overburdening people who want to volunteer or help with this issue.
Thank you so much, Noemi. And with that, it brings us to our next steps. And so we've already conveyed why it is so important that we address this topic. The standardization of healthcare in prison systems can have massive effects on them and on us. And so that brings us to the next steps. And so it's important that we continue to work on education, research, and funding, because the prison system is an extremely isolated group of body, and there's very limited knowledge for what we understand about prisoners and healthcare systems that run within the prison system. And so we encourage further education on this topic and research in order to better plan how funding would work from here. And this brings us to the conclusion of our presentation. We'd love to hear from you now. Thank you so much. Yes?
So from my exchange, we realized that in prison people experience a lot of the same health issues, just maybe a little bit more exacerbated. And additionally, in terms of security, first, there are different levels of security prisons. So some will be more high, maximum security, some will be more low security. But in terms of attracting physicians, I think presenting it as an opportunity that maybe is not equal but similar to residency programs is a great way for them to get their foot in the door and realize the issues that are out there. Additionally, I think the opportunity for mentorship, since you are partnered with an actual physician, it's not only going to be a greater outcome for the patient, but also for the student to actually see medical professionals at work. And I think that in itself is very valuable. I mean, I know for myself, even though I'm in more the legal and political realm, I didn't realize where my skill set and my passion would fit best until I shadowed people, until I asked people, and until I worked with them. So I think that mentorship aspect speaks a lot and is already pretty attractive in its own right.
And I can piggyback from there as my experiences as a medical student. We already have existing programs, such as I'm a part of the SFCC at the Herbert Wortham College of Medicine. So that's the Student Faculty Collaborative Clinic. So we're already targeting vulnerable populations in Opalaka. And so similar to that, you know, they can create programs. And so these would be physicians who already work with medical universities, and they would be the supervising physician, and they would have medical students under them. And so that's a big part of community engagement and volunteering as well, which would be really important to the university in general, the medical university in general, because it would give the medical students so much hands-on experience.
Sorry, just one more part to your question. I would also say, like, what would make it unattractive? Because these students are practicing medicine, and they shouldn't be discriminatory towards where they're practicing it. If someone needs help, they need help. And when you do become a practicing doctor, whatever you are, you're under oath that you're going to provide care to someone, regardless of who they are, regardless of what their race is, you know, all different identifiers. If they need help, they need help. So. I don't think it's any different in prisons, to be honest. You could see that anywhere. Go ahead.
I have a question. How will you be providing healthcare? Is it in the prisons? Where's this is just like small logistical stuff like equipment and staffing.
So yeah, it would be in the prisons. They already do have healthcare facilities there. We're trying to standardize the care because it's not standardized across the board, and that's where malpractice happens and injustice and all that stuff.
Additionally, when imprisoned peoples, which by the way is the term that I found is more appropriate, imprisoned persons are still able to get referrals outside of their prisons and they also come across a lot of issues there. So I think nipping a lot of these issues in the bud and making sure that the places in the medical facilities, like not medical facilities, but the medical room, whatever you want to call it, inside the prisons, I want to make sure that part of this, of like bringing people into it, is also realizing the lack of resources and funding. And I think that will in turn allow people to understand, sorry, my ADHD. I think that in turn will make people understand that like there's more need out there than we realize. And that in turn will make change, hopefully.
I have a question. So, who are you going to be looking for specifically for funding this program?
This double prong thing has me a little. Yeah. So again, the people that we said could assist with the problem. Were you talking funding specifically for what?
Monetary, yeah.
But specifically for what aspect? Like for funding things in prison? I think it would be a collaborative, again, effort between public universities and federal funding. The same way we get federal funding for a lot of things like the Aquarius Lab, the Wall of Wind, things like that are all funded by national organizations and federal governments as well.
But also the Payne Center for Social Justice, like we just went to, I think that's a great resource.
Like the nonprofits, think tanks as well could collaborate.
And the different committees in the Senate at the House.
I appreciate the great audience questions. To make sure we have enough time for all the presentations and for our special guests, I would like to our third panelist, Brittany, to be able to introduce herself. She'll be able to see the entirety of the rest of the situations, but then I'd also like to turn it over to see if Emily and Andres have any either questions or feedback for you all. Brittany, thank you for being here.
Do I have to push this on? No.
There it is.
There it is. Hi, everybody. Brittany Roy, Program Director for Public Health at the National Governors Association. Nice to meet you all and happy to be here.
Any questions or feedback from?
I'll start, I guess. I guess it's two-pronged, but did you guys do any research in terms of what exactly the standard of care is in prisons, in terms of staffing, roles, equipment, things that that currently exist in some of maybe the prisons, federal prisons within Florida at least? And my other question that would follow that is, are there any specific inequities or patterns in need for these patients, like that are most common?
So as far as your first question in terms of like where do we understand that the current problem is, on the research that I've been doing and my Exchange for Change partnership, which is required for the community writing class that I'm in, I've been able to do a prison letter exchange with someone who's actually imprisoned in Homestead, so not that far from us. And I have heard from them firsthand and also from family members of mine that are imprisoned and other classmates of mine who have been imprisoned or have family imprisoned. And it's been a really unique opportunity to hear, people tell me about how their medical professionals aren't always physicians. I've heard stories of people who have an ulcer and have to limp to the other side of the prison. And every time there's they have like a count of prisoners, it literally took them 3 hours to get there. And once they did, they only got like 1 or 2 Tylenol, if any. So there's a lot of issues in that sense. And then as far as some specific problems, we see a lot of issues with obviously mental health, getting specialty treatment, and also a huge problem is feminine hygiene. If you think it's hard for us out here to sometimes, know when to get our tampons and our pads, imagine for people who are maybe homeless or are in a prison. It's a very big issue, and reproductive health also falls under that category, I'd say.
Yeah, I thought it was a really great presentation. I guess I was wondering, it seems like a lot of the proposals are like community efforts, and like you're partnering with like universities and maybe like community health centers. I was wondering if if you know of like any like local legislatures, or if there's any other like, I guess, actors that are involved on this issue that like might assist in like funding or researching or any other parts of it.
No, go ahead. I don't want to be hogging it.
She said the one that we just came from. So the Payne Center for Social Justice. So that's a think tank. Yeah, that's a think tank. I think also that's why I wanted to pass to you, because I feel like as a medical student, you would know maybe more of the community ties that are done in the medical field as well. If you want to talk to that.
Well, I am not currently educated of specific medical ties in the prison system, but I know that there do exist. And there are many programs where physicians go in and work with prison systems. And so that's something we can definitely look more into to find the specific names. But I know that they do exist.
Thank you.
Thank you, guys.
Thank you, guys.
All right. Yeah.
Hi everyone. Hello everyone. So today we are going to be speaking about an integrative care model for gender affirming care. My name is Maika Eugene.
My name is Diana Duplord. I am currently a pre-nursing student.
My name is Michael Clark Jr., and I'm a bio major, and I work in the Office of DEI.
And I do apologize. My current studies is a master's of public health in health promotion and disease prevention. So when we talk about gender affirming care and the integration of care when it comes to this subject, we are speaking about having a well-rounded approach when it comes to clinical care for gender minorities. The barriers to care include bias, lack of education, lack of access to proper care, which you'll see some examples of throughout the presentation. And our team is dedicated to stopping the emerging changes in policy from affecting an upcoming public health equity issue. This would surround things such as harm reduction when it comes to other emerging endemics, essentially. So one thing that I do want to start off with, and our team really stressed, was the importance of definitions. So when we talk about gender affirming care, we're talking about things that pertain to gender affirmation, which means to protect one's identity and how they identify, and also integrative care. Integrative care is an interdisciplinary method of approaching the implementation science of creating a model.
And for me, I'm going to be reading solutions. So today's proposal is an integrative care model for gender affirming care. This will include a multi-sectoral approach, also that engages stakeholders from all levels, which you will see later on in our slides.
Okay, well, we're going to be splitting apart the stakeholders, but I'll go ahead and read the National Institute of Health. Specifically, we'll be targeting the National Institute of Health minority and health disparities. And specifically to target, well, for them, our target would be to protect research as well as access to research funds to promote clinical care. And then we also have the gender minorities and the community members that we'll be targeting specifically as well, being that they definitely need help. They'll be disadvantaged most of the times, like a lot of homeless trans individuals. They can't really seek the resources they need, such as medication, therapists, physicians, as well as general housing, stuff like that. So definitely, I feel like those are two things that we'll be targeting as stakeholders throughout our policy. And then I'll go ahead and pass the mic for the rest.
Our second stakeholder is the nonprofit and grassroots organization. These organizations would receive protections and maintain the ability to educate and provide effective resources for the care, such as Planned Parenthood.
Yes, so the policy that would be in place would provide protections for programs like Folks, Transsocial, and Planned Parenthood, because these are three of some of the biggest entities in providing gender affirming care. So this would be access to HRT, access to therapists, and even access to like needles to be able to inject their medication, and even other forms of care such as gynecological care and other types of affirming care. So essentially what we want to do is we want to provide the protections for this, because as we see in Florida, a lot of these things are under attack, for lack of a better term. And so we want to be able to protect these people so that it doesn't turn into a larger public health issue.
Not only that, we'll also be talking about in our policy about education in terms of like gender affirming education, as well as proper education of LGBTQIA things. Being that in the HB 99 Act, you guys know that's gonna not necessarily pass, but it's in the works. Things like that, so it won't be affected in the future, like trans health, as well as other policies won't be affected coming forth.
So one thing that we did want to stress is that this affects everybody. So every person that is in this room that gets some form of care, this affects. So as we look on this website, which is Folks Health, not only do they provide gender affirming care in the form of HRT and testosterone, but they also provide care for PrEP and and daily HIV prevention. As we know, HIV is something that is really prevalent in the South Florida area. They also have things like erectile dysfunction medication, which, as we know, is a form of gender affirmation care, and it falls under that. And they also have access to doctors who specialize in this. So our policy that we want to put in place would protect entities such as Planned Parenthood that offers like that one-on-one care and that specialized care for people who actually are specialized in this area of medicine. And there was another example, I don't think it's on this page, and quite frankly, I don't know how to use this that well. Okay, it is fine.
And that concludes our presentation. So we'll be open to any questions.
I just have one question for you, just in general, just in regards to the services that are going to be covered. Would speech therapy be a service that's covered as well? Because you didn't mention gynecology and any of the transition services, but speech therapy is definitely one that I feel like would definitely matter, especially for someone when it comes to, especially with a transition like that, and if they are taking hormones, as you mentioned, and their voice is getting deeper, or the pitch is getting higher, and they don't know how to control that because they're used to a different kind of pitch. So I just wonder if that would be something that would be covered as well.
Yeah, so our form of integrative care would be interdisciplinary. So this means different sectors of medicine and also of health education and promotion would be involved. So it would require a protection of these programs that are already in place, so that way they can bring these people in and also equally advocate for it and advocate for the research surrounding gender affirmation care, which encompasses a lot of other different aspects of medicine. Does that answer your question?
Yeah.
I was kind of curious as to if there were any federal level players that you would consider could help you with this initiative.
Well, one of the stakeholders was the NIH, most specifically NIH-MD, the minority health, as well as the health disparities in minority communities. So we would definitely ask them for help, and for research, obviously, and funding. So that
And
would be
government health and human services as well.
that we saw yesterday.
As long as we have them on board, it's easier for us to protect essentially the rights of people to have access to their own, healthcare and the healthcare that they need, and see fit for them. And so what we want to do is we want to have things in place to protect the right to do research for this, the access to funding that people get for this particular subject. As we know, because things are under attack, it's very hard to specify why someone would need access to the funds for something with even just the name gender affirming care. throws a lot of people off and people don't really understand it. So what we're trying to do is bring forth that gender affirming care is for everybody, because a lot of these places are in place for minorities to or historically marginalized people to access this type of care.
Any more questions?
I'd like to turn it to our panel. And again, you can have questions for them or even any feedback about how they could clarify or effectively present this to their stakeholders.
I guess I just want a little bit more clarity on exactly what the policy is or the change that you're trying to provide. From what I understand, it's state funding to certain organizations, and these are nonprofits and commercial entities that provide gender affirming care.
We want to enact protections to the policy that's already in place that is protecting people that fall under research for gender affirming care, actual care, one-on-one care, and also grassroots organizations. Because one of the things that is a barrier is access to funding. So as long as we secure that and we secure their right to access that funding, they would then be able to continue doing the work that they do, and also presenting it as a form of harm reduction, because without a lot of this education, without the access to this care, then we would have other things such as maybe someone won't be able to access their PrEP or like any of the other HIV medication that they would need. Does that answer your question?
Yeah, I'm just confused. What is Folks Health though? Is it an organization or is it just like an online?
No, it's an organization that provides gender affirming care and also access to therapists, doctors, and medication.
And to follow up on what she mentioned, I would also just say, like, with this policy more so being about protection, that will enable programs and people having accessibility to programs as such, and also other organizations that can be created with the federal organizations that we already implemented in our policy.
Yeah, thank you. So I guess the first question is there like any work or like have you looked into any like local efforts like that's being done like on these issues? Because when I was hearing the presentation, the first thing that came to mind was I know FIU a few years ago had like a sexual health alliance that like championed a lot of these issues, and they set up things like condom drives and like webinars on like sexual health. I was wondering if there's any like I guess like you mentioned like a local and grassroots component to it. I was wondering if you could I guess like talk more a little about that.
Well, like Transsocial is a local grassroots program that you would say, I guess. Really, the policy is not intended for like I don't want to say that. I want to say it's supposed to protect like those organizations from like being disbanded in the future in case like Congress comes to a conclusion they don't really want to do this anymore or something in regards to LGBTQIA plus health. Like they don't want to do it anymore, like, or they try to overturn like how they did Roe v. Wade. Like, I feel like that's a good example to compare it to. Not us necessarily like setting up those grassroots organizations or like outsourcing or trying to go find them. It's really like us trying to like make sure there's overall protection against all of them in case something happens in the future that like we just don't want them to be able to budge, basically. Oh, you have another question,
Oh yeah, sorry, thank you. I mean, do you have another response? Okay.
Do I have another response?
Yeah, or sorry, I thought you were passing it to her, but okay, I can just ask the second one. So I guess like the other thing is like, is this policy like, you know, if you were like pursuing it, would it be more like focused on like the state level or like the national level? Because I imagine like, you know, depending on like who you're bringing it to, you probably have like a very different response. Like, you know, imagine like, you know, for example, right, like Congress is like, well, actually Republicans on Congress, I almost forgot about that. But right, imagine like bringing it up to like someone like the executive level or like to the national level there is very different from bringing it up to someone like Ron DeSantis or something. I was wondering if there's any like thoughts there.
Well, that would all have to depend on approach. So if I was approaching it to the state level, I would definitely approach this from a form of harm reduction. South Florida has very high rates of HIV infections, and also they do have preventative measures, but those preventative measures are not always fully funded or fully staffed. So what this would do would implement a protection of securing funding specifically. And the reason why we said it's an integrative care model is that it's not just addressing HRT, estrogen, testosterone. It's also addressing that a lot of these care centers also provide free OBGYNs and gynecologists and people who specialize in different biological anatomy things.
Thank you.
I feel the pressure to ask a question. So everybody else is gone. So thank you guys for your presentation. It was very informative. Specifically, okay, tell me if I'm wrong here. What I hear you saying is we have an issue with lack of funding for organizations that provide gender reaffirming therapy, and the political kerfuffle, if you will, has added an extra barrier. And what you guys are aiming to do is to secure funding at the federal or state level to make sure that the people of the LGBTQ plus community has access to treatments and services. Is that correct?
Mostly
Okay.
correct. So the only thing that I would want to add in there is it's not just securing funding, but it's securing, I know I use the word protection a lot, but it's securing the language within the policies that affect how these organizations are able to secure funding, whether it's through research with NIH, NIHMD, or HHS.
Okay, so pretend like, and Eric, you stop me here if I'm doing this wrong. Pretend like you have like a draft bill, right? And you're getting ready to go in front of the state legislature to say these things. What is the policy you're specifically targeting? Like, I know you mentioned like Florida has some legislation that's out, but is there like a policy or legislation or something like a bill or law that you are aiming to overturn is not the right word.
Stop, block.
Yeah.
Well, I can say like HB 99 is a very good example. Like if something like that comes along in like the next 5 years after, well, I could just say now because it's happening now. If like we want to make sure there's ability to keep these programs going, like and not be affected by anything that passes. Well, like even if it comes into office, or I don't know what they call it, but even if it goes in there, like the first round it gets through, and then like I don't want to say it actually gets passed, but like it gets passed or like gets very close. Like we don't want like any of these programs to have to stop what they're doing in spite of that. Does that answer your question?
That does answer my question.
I would also just like to add that I think the hardest thing about creating policy or policy reform around a subject like this is that people don't understand clear definitions about what we're trying to do. And so I think, just for the audience and everyone here, understanding that gender affirming care is not it's not as like polarizing as the term is very polarizing, but what gender affirming care is, there are people who need access to testosterone that are cis male, right? We want to be able to protect that, and so that way they're able to access that. We want it to also be affordable as well for people who maybe are not able to access that form of care. So there's just a lot of different nuances that maybe would need to just be defined more clearly. We had for like 30 minutes. That would just need to be defined more clearly, so that way we're able to better educate and like present this.
That makes sense. Eric, are we allowed to give advice? Okay. So you'll take this with a grain of salt. For future. When like you get to the point where you are going to present something like this, ideally you'll have more time, right? Like more than 30 minutes to get through it. I agree with you with the education piece, because the 24 news cycle, like you see all these things, it's scary. If people fear what they don't understand, right? So that education piece, when you brought it up, I hear that there's like an equity concern, and if you marginalize this community for whatever reason, you're essentially marginalizing other communities, and so now we have like an equity issue, right? And then to your point about the education piece, thinking through like, are there organizations or companies doing the work where you can hitch yourself to their wagon, if you will? Like, we do a lot of work in HIV, STIs, etc. But we don't stand on that alone, right? We bring in people like Johnson & Johnson and Gilead and GSK and Walmart and things like that to help us like make the case. So I think you guys did a good job, and thank you for helping me understand what you were saying. I appreciate it.
If there's one takeaway that I would like to announce to the group is just like how we address different populations that we would like to work with. So like addressing historically marginalized populations such as the LGBTQIA plus community. Like we really just need to stress the importance of like educating ourselves regarding that language that we use and also the definitions of the things that we're saying. So thank you for your time.
Hello, can you guys hear me? Yes. Awesome. Good afternoon, everybody. Thank you for joining us. A lot of you didn't really have a choice, but I appreciate the panelists, Emily, Brittany, and Andres. Thank you so much for being here. So we're gonna go ahead and introduce ourselves first. So my name is Rayanne. I'm a master's student. I'm studying Health Service Administration at FIU, and I'm the president of the Healthcare Executive Student Organization at FIU. Working along with Kat. She's my VP. Shout out, Kat. But yeah, thank you so much for being here.
First of all, thank you for being here. My name is Megan Foro, and I'm a first-year undergraduate student majoring in psychology. Something I'm really interested in mental health, which will be really important for our presentation. You'll see in a bit.
Hi, my name is Patricia. I am a biology and psychology double degree senior student at FIU, pursuing a pre-med career.
Hello, my name is Jade, and I am currently pursuing my bachelor's degree in public relations.
Thank you for being here. My name is Aid Mokhambetova Nazirke. I'm a major in Health Services Administration, and we're here to talk about mental health and how overall it's important and equal as any health.
Hi, my name is Alvine, and I'm pursuing a PA program, and I'm double majoring in psychology and natural and applied sciences.
Alrighty, so our program proposal is titled Addressing Mental Health Disparities in Children by the Promotion of Mental Health Providers in Educational Programs. So why are we talking about this? Because we want to be proactive, and studies show that there's been increased presence of mental health issues after COVID-19, especially since a lot of children were isolated in their homes and were not allowed to really go out there and experience real life within playgrounds and schools and things like that. So their social settings really changed, and that had a really big effect on their mental health. And more specifically, there was a general increase in mental health illness. It increased from 19.2% to 21.6% in the last year. And we're also wanting to discuss this because there's increased acceptance in, mental health illness. This is something that used to be taboo. And so it might not necessarily be just an increase in the presence of mental illness, but also the acceptance and the recognition of it being there. So it's no longer as taboo, thankfully, and finally. And so we wanted to look into this because more specifically, we're seeing a disparity where there are not as many psychologists or mental health counselors that cater to children, and also the ones that are there are also being overworked, and the amount of referrals that they get, they can't really address them in a timely manner, so care is being delayed, for sure.
So to address all of these issues, we want to bring a program to universities in which they will receive funding to incentivize students to take part in a master's program for counseling, particularly, of course, in children. These students that would take part in these master's programs would then, through that funding that the school would get funding for either their tuition or their clinical hours, which they are mandated to do and are typically not paid for. We know that tuition and clinical hours can be a inhibitor in people pursuing a career in mental health, even when they are super passionate about it. So this is something that we want to bring not only to incentivize people to come to the program so that way then they then can get their clinical hours as well as the funding that they may need and then can work with students, but also so that universities can gain more of these students. And of course, we know with more students comes more and more students with more money and comes more resources.
I also wanted to go back and just tell you guys more about the data that's present regarding this matter. Sorry. So there are psychologists that are working beyond capacity. More than 4 in 10, so 41%, reported being unable to meet the demand for treatment, which has increased 30% from last year, and 46% said that they felt burnt out. And that's something that's very relevant. There's a lot of physician burnout. Other data also lets us know that the number of psychologists who reported receiving more referrals this year almost doubled from last year. And almost 7 in 10 psychologists, so about 68%, have a wait list that's reported that's been growing longer and longer since the start of the pandemic. And they're not really being able to catch up, unfortunately. So that is why we are addressing this matter.
And I want to talk about our stakeholders. And we have 2 stakeholders, and main of them is Patient-Centered Outcomes Research Institute, who is helping to study guide and make a design for the study programs, because our main reason for making this program is to show how mental health is important in every age and every stage of your life. And mostly we're going to show for the children, for the master program students. And the second the next stakeholder is going to be Congressman Napolitano. She's a congressman in California, and she made a lot of research about mental health. And she addressed that in every 3 Latina woman had finished with a suicide in 2001, which is a big concern. And she made a program which is in LA County Department about mental health. And the program really succeed. And I think these 2 stakeholders can help us with succeeding in our program as well.
And another importance that this program is going to kind of help with is it's going to trickle down to like high school and elementary, because we were thinking that eventually programs would have to be introduced in the education system. So we'll need mental health care providers to be able to help in these programs. So we're hoping that the funding could, help with that.
Yes, and we also do have a couple other stakeholders that we definitely want to reach out to. There have been amazing people that we have been introduced with yesterday. So we did learn about SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We definitely want to reach out to them for any assistance that we can get for this program. And also NIMH, who are the National Institute of Mental Health. They are a part of NIH, who we also worked with yesterday. So I think these are really important stakeholders to reach out for, if it may be funding, advice, or any kind of support that we can get for this program, for sure. And I'd like to move on to cost and resources for this program. We looked at a lot of data, and there are the states ranked from, the states that have adequate care for child, mental health illnesses. And the lowest in those categories were Washington, Tennessee, Texas, North Carolina, Wyoming, West Virginia, Oregon, Alaska, New Mexico, Arkansas, Arizona, Idaho, and Nevada. So we definitely want to start this program as a pilot program in order to implement this program within those states, because they are, in need of something like this. And this program would be funded through $10 million that we are asking for. That's what we calculated to be adequate enough to at least sponsor 500 students per state, so that in those 13 states. So yeah, so 500 students for those 13 states as a pilot. So hopefully we can take that data from that program and see, what changes we need to make in order to implement them eventually throughout all 50 states.
Now, we understand that is a lot of money, that is a lot to ask, but we also understand the fact that mental health is a national crisis. And honestly, it starts when you're young. If we don't implement these types of policies and these types of things for children, the problem is going to keep happening and happening and happening. And yes, of course, things can start when you're an adult, things can start when you are a teenager, but it's important that we implement these things from a super young age and that we make young children, especially young children, aware that it's okay to not be okay. It's okay to get help and that they have the resources and the opportunities to do so and that people do care.
And we're addressing this problem in asking for maybe such a big amount of money, and also because your life is a quality of your life. It's affecting by your mental health, well-being, your studying, your school, your career, and we'll have to compromise that. Sometimes those things may be asking for a lot of effort.
I just wanted to add that there are programs like this in place already. We have seen it in FIU. There is a program specifically through the master's program in rehabilitative counseling, but it's targeting disabled populations going back into the workforce or starting becoming part of the workforce. And basically our program would be essentially like an extension of that across the states that really need it. And the trickling down effect, it's similar to the program that they currently have because it would have a caveat where if they get the funding through our program, they would have to give back their work towards their state.
Also about our Napolitano, one of the congresswomen, and her program succeeded also in 4 schools, which extended right now to 35 schools, and she worked with the mental health and suicide prevention. And it's an example how these programs can succeed in just a few years, and yeah, we have to put it in a big accomplishment.
Okay, thank you so much. That's it for our presentation. We will take questions now. Yes, Michael.
How are you guys going to ensure that the students participating in the master's program are actually treating the kids correctly? Are you guys going to implement a supervising program? Oh, okay.
Yes, of course. For so those programs, they are going to be requiring a supervisor. Just ensure that they are getting proper training. We can't leave them unsupervised, and that way, those children and those students are getting the best care possible.
I'd also like to add that already within these degrees, they already require clinical hours. So it's basically just incentivizing people that want to pursue this degree, but maybe cannot because of financial and all of these other issues. So they're already there. It's just more so adding on to bring people into that field because we are seeing a growing issue within mental health.
And I would like to add, just through the classes and the educational part of it within the school, they would learn kind of how to deal with these issues and how to teach them. Of course, we do need the supervision, but just know that both those things would be provided.
I have 2 questions. So, how do y'all plan to retain the people that or the master students to work in those designated states that do need the people after they graduate? And 2, how are you guys gonna combat just the fact that kids are very overdiagnosed already? Yeah, I guess that in itself is enough.
Okay, so I'm going to go first to your second question. From the overdiagnosis standpoint, I think a lot of that, from what I've heard at least, goes straight to medication. Whereas first, we're going to take more of a therapeutic approach, and we would train these graduate students to not automatically diagnose someone, but rather work with the student. And it may not necessarily be an issue that they need to have diagnosed, but more so something that can be talked through, worked through, and things like that. And so that would be implemented. And so we would go through the therapy approach first. And then, of course, if there was a psychiatric approach, then that would be followed.
I just want to add that this is a counseling system. This wouldn't be a replacement for a doctor or a psychiatrist. It is not the same. So if there's a need for them to be referred, that would be something else that would be addressed by the medical professional. This is not the scope of the program.
For keeping, you were saying to keep those students that are studying in that area. So I would say that it's like what we're doing right now, how we've come to DC and we're meeting with all of these people and recreating all these connections. These students are going to be going out into their, because they would, already they're going out into their field and they're creating these connections with these workers, and they may create like that passion with, or that connection with that school. And they would probably, they might want to stay.
And just from what I've heard, I want to be a clinical psychologist. So just from someone who wants to go into this field, it's a very emotionally taxing field. There's a lot of emotional ties. And so someone could have emotional ties to the school, to the students, and that could make them want to stay. They could like the area. They could even be inspired. And of course, with this program, we would accept those students who we think would want to keep working and would be inspired and would really benefit from this program.
About 15 minutes in the remaining for all the presentations. I would like to turn it over to our panel, since you all can discuss amongst yourselves at night as you explore monuments and whatnot and discuss policy.
That's what we'll do.
Thank you.
Well, thank you for the presentation. Even without a visual aid, I think it was really well done. I just want to clarify. So your proposal is specific. It's to create an educational program and counseling through like a university.
Yes. So what we want to do, we want to provide funding to those universities to promote and recruit students to complete this master's program, so that we are producing more mental health counselors. And within this program, we also are giving them that funding not only to recruit, but also to fund their clinical hours, because a lot of those programs do not pay you anything while you're getting those thousands of clinical hours, providing care to those students, to those children while you're still in school.
But it's a specific, you're looking to create like a degree program.
Yeah, like a whole new degree program. Yeah.
And like securing it on a state-by-state basis, like per state.
Yeah, exactly.
So look-alike bills, things like that. Okay. I think that's great that you have a specific policy. And I just wanted to note some things, because you mentioned some federal stakeholders like SAMHSA. There's also HRSA, Health Resources and Services Administration. I always get it confused. But I did do some work in this area before, and I think it's useful for your knowledge to know that there are things called like health professional shortage area designations, where mental health would be one of them. Also facilities like correctional facilities in the last presentation, they can be designated per need of area. And so some of these programs also help like fund like the nurses corps, things like that help people get employed and provide funding for that kind of workforce post a education like you guys are proposing. I would say that a scope of practice came up a little bit, and I think that's a good point to also make, is like think about like scope of practice for the specific area, and accreditation boards. That's probably a stakeholder you'd want to be engaging with. I don't really have any specific questions. I would think that your policy proposal would obviously, like you said, vary state by state.
Yeah. Thank you.
Thank you.
Cool. Yeah, I think your presentation was really cool. Part of the work I'm doing right now is like access to mental health services like in the military. So hearing about like you talking about all like the in access to mental health services is like really important. I guess like one thing is if the point of the scholarship essentially is to like address like the labor shortage of like mental health practitioners, have you looked at any other like barriers or obstacles that providers face when like trying to enter space? I imagine one of them is like not having the resources to go to school and to get that licensing, but is there any other barriers that you might think providers might face?
Well, I think definitely another barrier that providers might face is just the emotional toll that being a psychologist or being in the mental health field can take on somebody. I know it's a lot, and I know that with time you can kind of work through it and learn how to manage it, but I do know that could be another barrier for it as well.
Cool. Yeah. Thank you. Thank you. Yeah. I think it just you know, like part of the presentation, like getting to that root problem of like why there is like a lack of providers, I think is really important. The only thing I think of when I think of lack of providers is that like, you know, some Medicare or Medicaid like programs like don't like cover like or like don't reimburse like providers at like a well enough rate as like private markets do. So like that's one barrier that I thought of when I was like reading your presentation. I think maybe just getting more specific on like that root issue is probably good. But I think it's a really cool presentation. I think there's just so much parallel into like the work I'm doing right now. So it was really fun listening to
Thank you. I'm glad. I'm glad.
Last but not least. So at NGA right now, I promise, I tell long stories because I'm from Arkansas and that's just how we do. But I will we'll link it back together. We have a chair and a co-chair every year, Republican and a Democrat, it alternates. This year it's Governor Murphy out of New Jersey and he is focusing on youth mental health. And there is, like, it's just, COVID aside, it was already bad, but COVID exacerbated everything. So, like, kudos to you guys for like raising this and highlighting it as your policy initiative. I would say you brought up a good part about the barriers to care and things of that nature. As you guys are like, I was writing down some of the stakeholders that you listed. I heard somebody from like the legislative branch and maybe a federal partner. I didn't like maybe think through like the executive branch as well, like since you did touch a little bit on scope of practice and things of that nature. Like legislative arm is gonna write the bills, et cetera, but the governor ultimately has to sign off on it, right? So making sure you have support there, but then also thinking through those other stakeholders and barriers. Some of what we are seeing is insurance companies not wanting to play ball, like private insurance. I don't know if they'll ever play ball. But making sure you have those conversations with them as well. And even on the practitioner side, there are some folks who flat out will not accept Medicaid recipients. And so thinking through things like that, like how do you make the policy more robust by stacking it with all of these other stakeholders? My team at NGA, we have this saying, like, nothing for us without us. I'm sure you guys have heard it. So making sure, like, the people that will be impacted by your policy decisions are at the table helping you craft it. And then you brought up, how do you keep them in the States? Or the...
How do you retain them? Yeah.
Yes, how do you retain them? A solution to that is tying it to the money. You don't get your repayment if you don't serve 2 years in a rural area or something like that. So I think you guys did a good job, and thank you for sharing.
Thank you. Also, I love that you mentioned Governor Murphy because I'm from New Jersey. So.
So sorry.
Good afternoon, everyone.
Test.
Good afternoon, everyone. Firstly, I want to thank our panelists for their time and considerations. My name is Arlene Kwan. I'm an undergraduate student studying neuroscience.
Hello, everyone. My name is Naomi Bridget Williamson Kundasa. I am an international student from Tanzania, majoring in international relations, and I am in my third year.
Hi, my name is Gabrielle, and I'm a first-year PhD student in public affairs, and my research interest is maternal health and child health policies.
Hi, my name is Jose Mendez. I am a junior with a major in history and a minor in political science.
Hello, everyone. I'm Kram Abulmona, and I'm a freshman majoring in neuroscience.
I will be discussing the background to our attempted program. So in essence, organophosphate pesticides are a class of chemicals that are widely used in agriculture and residential settings to control both insects and pests. Organophosphate pesticides can cause overstimulation of the nervous system, leading to a range of adverse health effects. Exposure to organophosphate pesticides during pregnancy has been linked to developmental delays, behavioral problems, and decreased IQ in children. Additionally, organophosphate pesticides have been associated with an increased risk of preeclampsia, a serious pregnancy complication. And for our proposal, our motives and efforts reside with a proposal to commission a study on highly dangerous and commonly used pesticides in prominent agricultural areas that ultimately affect maternal health and fetal development.
So what this program actually is we want to make sure that we have a study that looks at the proposed benefits of banning those pesticides in particular, and I'm not going to name them because I can't pronounce them. Also, at the same time, we're going to be looking at incentivizing businesses and manufacturers in this study through a small pilot program to create safer pesticide options that are already out there, while also looking at alternatives, recognizing the cost this can have to the business world. We were also going to look at the long-term effects of those safer pesticides that have been proposed by organizations such as the EPA, recognizing that we want to make sure that they're tested and fully put into use before we recognize and just start banning and implementing new things. And we want to make sure to look at how we can incentivize those businesses on how to create new products and use those pesticides instead, because we understand that by banning products that businesses heavily rely on, there could be economic problems, people could lose their jobs, and we don't want that to happen, and we want there to be economic smoothness, I guess you'd say, because we wouldn't want that to go on, but we also want to make sure that we take care of maternal health. During this program, we're going to be practicing it in multiple different states that are agriculture heavy. During our conversations throughout on the Hill and yesterday, we were looking at Florida as a big example because of their sugarcane industry. We'd also be looking at states such as California and Texas, which are big on agriculture and the use of pesticides, and we want to make sure that we do multiple tests in multiple states on what's going on with that. Oh, and now we're going to be looking at our stakeholders.
Thank you. So with any policy, program, or project, it is important for us to engage stakeholders that can contribute to its development. So we identified the EPA, the Environmental Protection Agency, because they're concerned with the pesticide side of our program. HHS, who will be concerned with the maternal health side. And under HHS, would like to engage specific entities, so the CDC and their research arm, the National Institute for Occupational Safety and Health, and we also would like to work with the Maternal and Child Health Bureau, which is an agency underneath HHS. We also want to include state representatives who are in those high-risk areas that Jose just mentioned, areas that have heavy agricultural use. And on the international side,
so from the international side, we'd like to partner with World Health Organization, and this is mainly because we believe that enhancing and promoting education to some of the mostly African countries that are not aware of the effects of the pesticides in pregnant women. And also something else is that when this program pushes through, we have experienced an issue of having some of the unused products being dumped in Africa. So that is something that does affect Africans environmentally, and it's something that we would definitely want to work towards too. So that's basically why I would love to partner with international institutions.
So now for the cost and what we're actually asking for with this program. So we're asking for $100 million, which I know by the looks of your faces, you're like, what the heck? It's a lot of money. But this is a long-term widespread problem, so it requires a long-term widespread solution. So this is basically a basic breakdown of how that money would be spent. So we would need it for research teams, so for their salaries, and obviously for the equipment, any materials. As this problem has multiple different climates to test, different environments, we would need multiple teams, so different locations. And this would be a 3-year project for the initial phase. And just give me a second. Oh yeah, and then that's not only it, we would also use some of the money to save for the incentives for the businesses that we come up as another research project. And
Also, real quick, like we were mentioning, working with organizations such as WHO, we would also be using some of that money to make sure that we can we're testing safely getting rid of those pesticides. So it's a multiple part project that study that would look at different ways on how to do it. So it requires a lot of money. And if it is implemented across the board, it would require, granted, even more money, but the impact on maternal health with the studies out there of the dangers of pesticides is too big of a problem to not do anything just because of the price tag. Thank you. That's it. That's
Any questions? So I know you're addressing pesticides and chemicals as it reflects like an environmental issue. However, how does that impact industry that produces these pesticides and chemicals?
So one of
On board.
So one of the things is by having them involved in this study right away is how you get them on board. But when we're talking about the industries, recognizing that even if what they're making has a harm, there is a benefit to what they're doing. Pesticides are necessary for our food, and they are important to our economy. So we have to understand it in that way, that we have to work with them, because if we don't work with them, there's serious dangers to our food production, to people working, to the American economy, and getting them on board is by putting in money incentives, by saying the federal government wants to help fund you, doesn't want to just take away what you're doing and not leave you with backup resources. It won't be easy either, but by having those conversations and by putting actual resources to money where your mouth is, essentially, it'll be a lot easier than just saying it's banned, figure it out.
I guess I'm just gonna ask clearly, like, what is the policy solution? So what is your ask, and what you're proposing specifically?
So right now we just want to do a study looking at banning those very dangerous pesticides that, again, I can't pronounce, and using safer pesticides in a wider range.